What I'd like to do is give you guys a brief review of the clinical history and the pathophysiology of sarcoid, as well as show lots of images of both common and more unusual thoracic imaging findings in the chest, and just to briefly touch on the complex relationship of smoking and sarcoid. So sarcoid was originally described in 1877 by a pathologist named Jonathan Hutchinson, and it got its name because of skin lesions which look like sarcoma. It's a multisystem disease. It's characterized by non-caseating granulomas, and in 90% of patients it involves the respiratory system or the lymphatics, which is associated with most of the morbidity and mortality of the disease. And it also frequently involves the skin and the eyes. So there's a broad range of clinical presentation here. Some patients are asymptomatic or have very limited disease, while other patients have real debilitating disease ending in death, unfortunately. But luckily for 2/3 of patients, they have stable disease or they enter remission in about 10 years. And after remission, very few recur. Unfortunately, for 20% of patients, they go on to develop chronic disease and lung fibrosis. And in about 5% of patients, they end up dying from their disease, typically related to their pulmonary manifestations, and sometimes related to cardiac and neurologic involvement. So usually patients present when they're in their 20s, young adults. There's a variable incidence throughout the world, and it's seen more commonly in women than in men across ethnic groups. So the highest annual worldwide incidence is in Northern Europe, but here in the US, Black Americans are 3 times more likely than white Americans to be afflicted with sarcoidosis. Black Americans are more likely to have severe or chronic disease or extrathoracic disease, and white Americans are more likely to have asymptomatic disease. There was a paper published last year which looked at the mortality of sarcoid over about a 20-year period, and they found that mortality had increased about 3% per year. The highest absolute death rate was among Black females, and the greatest increase in mortality was seen in older patients over 55 years of age. And interestingly, the patients with sarcoid-related death actually died from sarcoid rather than superimposed or other complications such as lung cancer or even pneumonia, which actually was a surprise to me. So the pathophysiology, the etiology is obviously it's a big point of discussion for many people. A lot of people think that it's related to something airborne because of the frequent involvement of the lungs, the skin, and the eyes. Again, non-caseating epithelioid cell granulomas is what makes the diagnosis, and those are produced as a product of cell-mediated immunity. So what we have are activated alveolar MACs and T-cell lymphocytes, which produce interleukins and growth factors, and in turn those recruit more T-cells and fibroblasts. It basically sets off a cascade of cellular infiltration and chemical release. Serum angiotensin converting enzyme is frequently used by clinicians. It's a product of macrophages and an indicator of granuloma burden, but just a reminder, there's a 40% false negative rate. So clinically, if patients present with symptoms are typically respiratory ailments like cough or shortness of breath, systemic symptoms like fever, fatigue, polyarthritis. Those are also seen. I had forgotten about Lofgren syndrome, which is supposedly pathognomonic, and it's composed of intrathoracic adenopathy, erythema nodosum, and arthritis. So if you consider these 3 elements together with fever, those 4 actually convey a good prognosis for sarcoid. However, on the other hand, there are a few elements which generally portend a not so fortunate course, a bad prognosis, and those are an older age at diagnosis, over 40 years, and either lung parenchymal or airway involvement. And it's also very important to remember that in about 50% of patients, they present asymptomatically, detected incidentally on a chest X-ray. So let's start looking at some images here. Chest X-ray, usually the first foray into radiology for some of these patients. And bilateral hilar adenopathy is the most common finding, oftentimes in association with right paratracheal adenopathy. Other combinations are less common, obviously, but thank goodness unilateral hilar adenopathy is seen in a small majority of patients. So the older someone is at presentation, the more likely they are to have atypical lymph nodes. So nodes are oftentimes non-calcified. Those that are calcified tends to be related to duration of disease. About 20% of patients have calcified nodes at 10 years. And the calcification is often amorphous or smudgy or hazy. Sometimes it's eggshell. Here's a patient with hilar enlargement and paratracheal opacity, and the corresponding CT shows lymph nodes pretty much everywhere. We have some nodes in the anterior mediastinum, bulky right paratracheal adenopathy. We see involvement of the AP window, the hila are enlarged, and there's subchoroidal adenopathy. So here's another patient. The hyla are prominent, but it's almost overshadowed by this right paratracheal opacity with involvement of the tracheobronchial angle. And even on this non-contrast study, we can see that there are enlarged nodes in the paratracheal region next to the aortic arch and creeping into that anterior mediastinum. The hyla, there are some nodes there, but they're sort of overshadowed by the disease above. So chest radiographs, oftentimes there's the Siltzbach staging system, which was developed 40 years ago and is oftentimes still in use. It generally conveys a good prognostic value. This should be something that most of us are still familiar with. Ranges from stage 0, which is a normal X-ray, to stage 4, which designates fibrotic lung disease. 50% of patients have adenopathy, so that's stage 1 disease. Additional disease basically indicates parenchymal involvement. So here's an image. Hilar enlargement, right paratracheal opacity, and there are also some ill-defined parenchymal opacities at the bases. So this would be a good example of stage 2 disease, adenopathy and parenchymal involvement. So most patients go on to get CT, for better or for worse. It allows us much greater sensitivity for early disease or subtle disease, frequently using high-resolution protocol where we use thin section images. This can really help detect more subtle nodularity, ground glass opacity, reticulation, things you might not see so well on a standard chest CT. One of the best, the greatest advantages is really to be able to assess active, reversible, or treatable disease like nodules, lung consolidation, and oftentimes ground glass, in comparison to chronic, fibrotic, or irreversible, basically non-treatable disease, which is bronchiectasis, architectural distortion, or perhaps cystic changes. And again, it's important to note that a negative CT doesn't exclude the presence of sarcoid, unfortunately. So parenchymal disease usually starts as an alveolitis or an interstitial pneumonitis of the alveolar walls. Again, T cells, recruiting MACs, and the macrophages morph into these epithelioid cells. They coalesce to form what we call granulomas, and they typically congregate in lymph nodes and areas of the lung where there's a rich lymphatic supply. So what that means is subpleural spaces, the septae, the peribronchovascular regions, and of course that gives us our characteristic perilymphatic nodules. So on CT, we're looking for nodular thickening of the fissures and the pleural surfaces, nodular septal thickening, and thickened bronchovascular bundles. So here's a patient with nodular septal thickening of all the fissures. A little bit lower down in the chest, same patient, we see pleural nodularity and irregular thickening along the lateral margin of the right lung base. Another patient with nodular septal thickening. The image on the left could be confused with lymphangitic carcinomatosis if you had no history whatsoever. And finally, a case of pronounced bronchovascular bundle thickening in the right lower lobe. So here's a patient which seems to have a little bit of everything here. If you look at the images on the top, that you have a nice example of nodular septal thickening. There's also bronchovascular bundle thickening. And then the images on the bottom are a great illustration of nodular thickening of the fissures. Here's a patient with what looks like primarily adenopathy, hilar paratracheal opacity, which is confirmed on a non-contrast CT. But 3 years later, the follow-up imaging, it's not so much adenopathy picture. Now we get more of a sense that there's a central predominant lung reticulation. So it's changed over 3 years. And the CT that followed that X-ray shows this. So there's really pronounced bronchovascular bundle thickening. There's also some septal thickening and pleural thickening and nodularity, but the bronchovascular bundle thickening was really pronounced in this patient. Here's another patient. There are perilymphatic nodules in this patient. We see nodular thickening of the fissures and even some ground glass in the right hilar region. But in the upper lungs, it looks like the nodules have more of a random appearance or random distribution. Certainly not all the nodules are perilymphatic. And in some areas, like in the right upper lobe, some of these nodules sort of have a clustered appearance, like perhaps suggesting maybe even a central lobular distribution, which would be really unusual with sarcoidosis. Here's some images of the lung bases in the same patient. Again, a few of the nodules are clustered, but overall, despite the presence of perilymphatic nodules, there was sort of a random distribution in this case. Here's another patient this was a man in his 50s who actually came in recently to our hospital. Abnormal X-ray with a diffuse micronodularity, sort of looking granular and ground glass opacity, and the corresponding CT showed that as well. What we thought was a miliary pattern of micronodules, best seen at the apices, and then as you go down towards the bases, nothing spared here. It involves the entire lung, but it sort of, again, produces this granular or ground glass opacity, and path on this patient showed non-caseating granulomas. Interesting case. Yet another X-ray. This shows widespread reticulation, oftentimes somewhat nodular in appearance. And the CT illustrates that as well, some upper lung predominant reticulonodular lung markings in a patient with sarcoid. So what we've seen so far is a fine nodular pattern or a reticulonodular pattern, but oftentimes these nodular opacities coalesce. So in over 50% of people, they have at least 1 centimeter size coalescent nodules. You may have air bronchograms, or you may not. You can have satellite nodules, which is referred to as the galaxy sign, and you can have ground glass opacity, which is usually related to extensive interstitial granuloma infiltration. So ground glass is usually associated with active disease, but you can also see it with chronic fibrotic disease. It sort of bridges the gap between acute and chronic sarcoid. Coalescent nodules can be acinar, basically poorly marginated, somewhat stellate nodules. They can coalesce to form alveolar sarcoidosis. And fortunately, focal nodules or masses are rare, and they oftentimes require tissue sampling to exclude malignancy. Cavitation is also very rare, true cavitation that is. Several studies, everyone seems to be less than 5%, so it's pretty uncommon. So here's a patient with characteristic nodules. They're poorly marginated. They're primarily in the upper lungs, sort of a stellate appearance. This was a sarcoid patient. Here's another patient, actually 2 patients, with irregular nodules, somewhat stellate in appearance. And the patient up top, if you look at the right lung, these nodules sort of coalesce to form an alveolar sarcoid picture. Here's another recent patient we had, a young patient, young female who came in with widespread nodularity. And if you look at the arrows are denoting some upper lung nodules, which look like they may be undergoing cavitation. So the corresponding CT there showed irregular nodules, some of which were indeed cavitary. This patient was lost to follow-up, unbelievably, for 6 months, and when she came back, granted we only have a few images here, but nodularity had increased, the cavitation had increased significantly, lungs looked horrible. A patient went for an open lung biopsy. This was actually diagnosed as necrotizing sarcoid granulomatosis, which is sort of a subset of sarcoid, primarily characterized by a vasculitis and associated necrosis. So that's why she has such a wide extent of cavitation here. We actually saw this image before. This is our stage 2 disease. The corresponding CT shows some nodular mass-like areas of consolidation, some of which have air bronchograms like we see in the right lower lobe. Yet another patient, upper lung predominant, heterogeneous lung opacity. And this also shows another case of alveolar sarcoidosis. Interestingly, at the apices, you can see that the airways are a little bronchiectatic, so that suggests that this disease has been around for a while. This X-ray looks primarily like adenopathy to me, but the corresponding CT shows some micronodularity of the fissural surfaces, and there's also a frightening, scary-looking, irregular consolidation at the right lung base. We can also see on the reformatted coronal image. So when we look back at the X-ray, I still think this is like my worst nightmare. I guess there's a faint opacity there at the right lung base, but honestly, I think this may be an easy miss. So the patient was treated with steroids, and after treatment, re-imaged, and the micronodularity resolved, and thankfully that irregular right basilar opacity shrank significantly. It left some residual streaky opacity in an area of focal bronchiectasis. This is another patient with a focal consolidation at the right lung base. Everyone thought this was cancer. It was actually sarcoid. So 20% of patients go on to develop lung fibrosis, and just like acute disease, the distribution is primarily involving the upper and the mid lungs. And we see classic fibrotic findings, so linear opacities, airway distortion with traction bronchiectasis, and architectural distortion. Sometimes we can see fibrocystic changes with bullae, cysts, honeycomb-like cystic changes, and rarely, again, cavitation. If cavitation is present, it's usually pseudocavitation with a fibrous lining of that cystic or cavitary space. There was a paper published about 10 years ago which looked at patients with sarcoid-related pulmonary fibrosis, and of the 80 patients in that study, about half had bronchial distortion, so that was the primary or common finding among them. And honeycombing and linear opacities were much less common in those patients. So we'll take a look at a few cases quickly here. This is a patient with some widespread traction bronchiectasis. There's volume loss and architectural distortion, ground glass opacity, some scattered reticulation. Here's another horrible patient with some cardiac disease and definitely abnormal lung parenchyma. And here's the corresponding CT. So these images also have a little bit of everything. At the right apex, you could consider that there may be some honeycombing. There's also traction bronchiectasis, ground glass opacity, and reticulation. This doesn't spare any area of the lung. This involves the apices all the way down to the bases. And this patient had a long history of sarcoidosis. Here's another patient. We see these characteristic stellate nodules, but in this patient, the hyla are enlarged, sort of a conglomerate mass-like opacity, and they're retracted posteriorly with associated traction bronchiectasis. This is another patient, similar findings, but what we see in this patient is a lot of ground glass opacity. So one of our last cases of fibrotic lung disease. What we see here is hilar enlargement, paratracheal opacity, but we also see widespread reticular, somewhat cystic-looking spaces. Looks like it involves the entire lung, but it looks more prominent at the bases. And on CT, you might not think this was sarcoidosis. We see traction bronchiectasis, and we see honeycombing, but it's basilar predominant. So sarcoid would certainly not be on the top of your differential, but in case, strangely enough, that's what this patient had. Another case, this is a patient younger than you may think, but there's extensive bullous and cystic change involving both upper lungs. When we look at the axial images, you can see that there's also a mycetoma forming in the left upper lung, lots of destruction and distortion of that right lung especially. But interestingly, I just want to point out that the bases actually look pretty good in this patient. It's another patient with lots of ground glass and evidence of air trapping. So with that, I want to sort of segue quickly into airway involvement, which is oftentimes overlooked. It involves about 2/3 of patients, and it's associated with increased morbidity and mortality. So it's something important to consider. It goes from top to bottom, so to speak, oftentimes producing mild extrinsic compression from enlarged lymph nodes, but it can also be intrinsic airway disease, mucosal inflammation, and areas of stenosis intrinsic to the airway itself, rather than extrinsic compression by enlarged nodes. Any sort of extrinsic compression is usually not very clinically significant. Large central airways are not involved commonly. Usually involves medium-sized airways, but this was a patient where sarcoid was on the differential. What we see is a circumferential thickening of the trachea, the main stem bronchi, and even some segmental airways. But most airways are lobar or segmental bronchi when they're involved with sarcoidosis. Early stage disease includes edema, inflammation, and infiltration with granulomas, and that produces this characteristic nodularity or cobblestoning that we hear about from our bronchoscopist colleagues. It also develops not just within the airway, but along the bronchovascular bundle, as we mentioned before. So in the early stages, it can result in some luminal stenosis and narrowing, sometimes some atelectasis, but surprisingly, the symptoms are usually fairly minor. And then, of course, as disease progresses, you get some fibrotic changes either from intrinsic airway involvement or from surrounding parenchymal involvement pulling those airways open. So it can be either directly related to the airway itself or the surrounding lung that's involved. This slide we've seen before, just sort of reiterating that bronchial distortion, airway distortion, is the most common fibrotic finding associated with sarcoidosis. So small airway disease can occur in early disease or late disease. It can be seen with or without parenchymal involvement, and we typically see this with expiratory images. Air trapping is seen in the large majority of patients with sarcoid, up to 95%, in a study performed by Davies and colleagues. Here's a patient with acute disease and evidence of air trapping. And here in the flip side is a patient with chronic fibrotic lung disease and air trapping. So it sort of runs the gamut. Hemoptysis is usually related to a complication of aspergilloma rather than traction bronchiectasis. There was a study last year by Peña and colleagues that looked at over 400 patients and found that about 2% of them also had to deal with aspergillus infection. So this was only seen in patients with fibrotic lung disease from sarcoid, but it was seen more commonly in sarcoid than other chronic lung diseases. And although there were only 10 patients afflicted with this complication, the outcome was actually pretty bad for several of them. 3 patients out of 10 died. So it's a potentially very serious and fatal complication. So here's a great example of a patient with Monod sign. There's an air crescent and heterogeneous opacification of the right upper lung, and corresponding CT images demonstrate our mycetoma. There's also some honeycombing or honeycomb-like changes in both upper lungs. So smoking, it's very interesting. There's been a lot of work on smoking and as it relates to sarcoidosis. And there was a study in 2004 called the ACCESS study, which found that the odds risk of sarcoid in patients who had ever smoked, meaning current smoker or ever smoker, was significantly lower than people who have never smoked at all. And so lots of studies came as a result of this. One such study looked at CT findings and found that smokers had a decreased frequency of bronchovascular bundle thickening than non-smokers. And since bronchovascular bundle thickening is associated with airway obstruction, some people assume that bronchovascular bundle thickening can be sort of a surrogate marker for assessment of disease burden or airway obstruction. A couple other studies have looked at exactly why smoking might produce a decreased odds of sarcoid. And basically the thought is that smoking decreases the inflammatory response or decreases the immune response, which allows granuloma formation in the first place. So pleural involvement is pretty uncommon. It's 10% or less of patients, usually small or moderate effusions, which clear after a few months. And one interesting complication or sort of a variant is a chylothorax, which involves infiltration and obstruction of the thoracic duct. This is very uncommon. This is a patient we had in Brooklyn, a 36-year-old who came in with acute symptoms to the emergency department. He had a low-density pleural effusion. He also had chylous ascites. He had airway involvement. Really interesting case. So this is our case of chylothorax. And I just want to remind you very briefly, I don't read nukes, thank goodness, but nuclear medicine can be used to assess the presence of active sarcoidosis and looking for extrathoracic disease. It's very useful. Response to treatment, for example, using gallium citrate.